you're searching for treatment programs and you see it on the website. It says Joint Commission Accredited or CARF Accredited. So you assume that means something. It does, but probably not what you think it means. So, and definitely not everything the program wants you to think it means. So I'm going to tell you exactly what accreditation is, what it verifies, and what it doesn't, because understanding the difference could change the questions you ask before your loved one actually walks through those doors. So I'm Dr. Angela McMahon. I spent over a year consulting on the Joint Commission and accreditation licensing as well for behavioral health and substance use disorder, SUD addiction treatment centers across the nation, primarily in California. However, I have done several in other states as well. So I'm familiar with the accreditation process more with the Joint Commission, like their early survey, their post-licensure survey, but I have experience with both. And I've been on both sides of the survey process. So here's what I know. What accreditation is. So accreditation is voluntary. If you want it, that's great, but it's not required to open your doors. It's not required in California and in many other states. However, there are certain states where it is required, and you actually have to do what's known as an early survey in order to get your state license. For example, the state of Ohio is like that. So keep that in mind. There are certain states. However, most states do not require it. So, however, a lot of payers do. So if you want to use insurance, or if you're an organization that wants to get reimbursed by payers, then you're going to have to go for this accreditation in order to accept more payers. And they're independent third-party evaluations against published clinical quality standards. The Joint Commission, TJC. It's the oldest and most recognized accreditation body in healthcare. And I think it was like 2007, 8-ish, where the Joint Commission changed their name. The acronym was JCO, or pronounced JCO before, but the branding was so good that people still call it JCO to this day. I can talk to them about the Joint Commission and they say JCO, and often the acronyms are all like jumbled up and not really what it actually was. And I don't even know what it was, but I know TJC is the Joint Commission, and it's been that way for a very, very long time, almost 20 years, right? So CARF, though, it means Commission on Accreditation of Rehabilitation Facilities Behavioral Health Specialists. So those are the primary two biggest accreditation bodies. Both conduct on-site surveys. They call it a survey. State usually calls them site visits, but Joint Commission has their surveyors, as where the state typically has their analysts. And, it can be by trained peers. So typically a surveyor, at least for the Joint Commission specifically, is a licensed professional. So like a licensed nurse, psychologist, therapist. Usually there is a requirement for them to have a license. And they're usually independent contractors who currently work in the industry. Maybe they work at a treatment program, own a treatment program, a hospital, and they also do surveys on the side. So, and they can come from any state because the standards are written in a way to where they're vague enough to where they can be applied to every single state. Keep in mind, the state always trumps the Joint Commission standard. So if the state says you have to do something a certain way, then you have to. However, what the Joint Commission could come back and say, because a lot of their standards, their elements of performance or EPs within the standard, usually requires that you, like, for example, human resources management says regarding background checks, the element performance says you follow your state law or organization policy. So you default to state law, but then the Joint Commission surveyor sometimes can come back and say, okay, well, why aren't you doing better than the state law? And you have to at least meet the minimum requirements. However, you can do better than that if you want to too. But you also don't have to. If it's working for your program to not provide services beyond what the state is expecting, or, like, for example, if rounds to check detox clients are every 30 minutes and the Joint Commission hopes you do it at 15 minutes, well, maybe you're not doing it 30 minutes because it's just not enough time. The 15 minutes, you're not logging it properly. So now we're having a bunch of issues where you're not following your own company policy because someone logged it at 16 minutes or 17 minutes. So maybe you stick with the state law. However, you hope that they can do it sooner. Things like that. So there's just a lot of different ways to play around with that. So, and both publish their standards publicly. Accreditation is time limited. So usually it's approved for about 3 years. 3 years. However, you reapply and then you have a re-survey every cycle. Typically, they come between years 2 and 3 in the Joint Commission experience that I've had. However, lately they've been coming closer to year 3, but they technically can. And also if there's a complaint and they feel like it's necessary to come out and do an investigation. I don't see that commonly happen. If there is a complaint, it's usually to the state, but it could happen. So it can be revoked. Point number 2, when the survey process actually looks like. This is what it actually looks like. So surveyors arrive on site. They're announced for the Joint Commission. It can be unannounced, but typically it's announced. It's an initial. Usually you pick the ready by date, and they usually come on that date or after. Most of the time in my experience, they come on that date. Lately, they've been coming a little bit after, but that's getting better. And also, they can come unannounced or give you a few days notice ongoing. So keep that in mind. Staff interviews, like clinical staff, administrative staff, leadership, that is conducted while they're there. So clinical staff, they go over what's referred to as a tracer, which is a chart, a client chart from start to finish. So you're required for an initial to have at least 3 served clients and 2 active. Served means like closed chart, basically. And so you're giving the surveyor an opportunity to be able to review your client file from start to finish, admission, intake to discharge, and maybe even post-discharge. And so that helps them if you have at least 3 closed files. And active clients, you can see what they're currently doing in real time. And so those are considered tracers. Administrative staff, they'll look over your documents and making sure your policies are intact and that they're up to the standards and that they're all there. And also that what you're saying you're doing is actually happening in real time. So if you say you perform a certain screen within 24 hours, then when they're doing their tracer, they could look and see if it actually was done within 24 hours. Are you following your own internal policy? Leadership gets interviewed because they like to talk about what culture of safety you provide. So collaborative, right? Open door policy. Those are the things that they like. Those are the things that are healthy. We don't want one person having all the power. We really don't like punishment. We like to collaborate and we like to learn from situations. And that seems to be a pretty good environment. Client interviews, if they want to do a client interview, they can. So it's up to them. Like sometimes they do, sometimes they don't. And one of the questions that is almost guaranteed to be asked of a client is, well, what do you like about the program and what would you improve about the program? Record review. So that's what we talked about, the tracer, the clinical records, policies and procedure, incident reports. Incident reports are big. Then also you do the physical environment walkthrough, which is done typically with someone identified as the safety officer. And this person will go through and do the tour and look at all the fire safety equipment, make sure that everything looks really safe and secure. Typically you would see staff with some sort of identification on them, because that meets the standard for security. And so those chapters usually include environment of care, emergency management, also is overseen by the safety officer, life safety, if it's a residential treatment program. And then this is actually a very important piece for leadership as well, because during your leadership meetings, when you identify how often they happen, but they need to be regularly, it's the word Joint Commission uses. And during those meetings, you have to talk about safety and security issues as well as performance improvement. So, and then performance improvement. So that's the data collection, right? So you're talking about it in the leadership team, you're discussing the concerns that are going on. within the organization. It's not limited to clinical. Sometimes programs think it's just clinical, but that's actually not the case. You can do any department, and business development, clinical, any department. And you just talk about what are your priorities, and then you focus on the priorities. You do your root cause analysis. You're going to talk about high risk, high volume, problem prone, what is going on here. And then you put your performance improvement activity into play, and you set a goal for it, a goal that you can quantify. So you can measure, is this effectively working? Am I reaching my goal? And then you can adjust based off of what you're seeing, patterns and trends. You may decide you didn't reach your goal, but you don't need to continue to focus on that one. That's fine. Or you can have several open at once. One may take a month, one may take a year. It just depends. But there are some performance improvement activities that the Joint Commission requires you to gather information on. And then there are some that you guys are going to figure out what they are as a leadership team. And based off feedback from staff also, they can have input, people that are not a part of the leadership team meeting. Then the Joint Commission is going to have their exit conference where they present all the findings or scores to the organization. And the survey report gets submitted. Accreditation decision is made once you address the deficiencies. So you have to actually do the deficiencies before, at least that's the rule, before you submit them. So you can't say, we will do blah, blah, blah. You say, we have done and we are doing blah, blah, blah. No clients were harmed because this standard wasn't met. Things like that. There's a whole process on how you complete the deficiency report and submit for evidence of correction. Point number 3, I'm a fast talker, I'm sorry. There's a thing where you can slow this down if you want to hear me speak slower. Point number 3, what accreditation verifies. The program met published standards at the time of the survey. Clinical policies and procedures are documented and followed. There's evidence. Staff credentials meet the minimum requirement for accreditation, which isn't a ton, but that can be dissected. Anyway, it is a ton, but it's not. Okay, that's it. Anyway, client rights are protected and documented, and performance improvement processes exist. Leadership structure is functional, and the physical environment meets the safety standards, especially regarding fire safety, disaster safety, ligature risks. Ligature risks, self-harm risks, that's huge. That's extremely important. So these are meaningful quality indicators, which really significantly above licensing alone. Point number 4, what accreditation does not verify? Treatment outcomes. Accreditation does not require programs to demonstrate their treatment works. However, there's a care treatment and services CTS standard that does talk about using standardized tools to gather that information and put it to use in the objectives of your treatment plan. So like if you're doing a PHQ-9, you get the outcomes of that, and you say the person's at this number now, we want them to be at this number within a week. And it's got to be achievable and reasonable. So you can't say they're at a 7 and we want to take them to a 0, that make it more reasonable, like 7 to a 5, something like that. And then, so that's at the client level, but then they also require that you track clinical outcomes at the program level. How you determine you want to set that up is completely up to you. And the outcomes of that, you guys use as an internal resource to determine patterns and trends where you need to improve. You get information from that. So, and then hopefully respond based off of what you're seeing. So every single standard is supposed to be met every single day. But I know sometimes it's hard, but that's the goal. Staff conduct between surveys, like how are they acting and what are your billing practices? Accreditation bodies do not audit insurance billing, so keep that in mind. But they do require that you have a budget and you're working within your budget, you manage it, monitor it, and marketing honesty. What a program says in its advertising. Although I will say, in my experience, I see that the state usually oversees that more, but you're supposed to be, being honest about what's on your website. There's an organization called Legit Script, which heavily monitors that as well if someone chooses to get Legit Script for Google advertising, for example. And whether the program will maintain the standards after surveyors leave. You got to maintain them. What processes do you have in place to maintain them? It should be structured. It should be set up. It should be addressed. It should not be the surveyor's gone, whatever. We'll deal with it in 3 years, because let me tell you, it's not fun in 3 years. And the financial integrity of the organization. Point number 5, CARF level of care certification, what it adds. So that's CARF LOC 3.7, which is a medically managed level of care in California. It's a non-medical treatment program. So level of care that exists. Your options are 3.1, which is residential low level, and you could get 3.2, which right now is withdrawal management, detox. And then there's 3.3, which could include, situations where someone has like a TBI, something like that, and that they're dealing with, and you're going to help them with. So then there's 3.5, which is, the higher monitoring residential level of care. And that's as far as it goes. Well, there is a need for LOC 3.7 in programs. And if a state offers it, great. However, in the state of California, they don't offer it. And so that requires more medical oversight. And this is a risky business. People are really sick when they come in most of the time. So it is really important, and it can be life or death. So it's really important to have this piece in many cases. It's a great addition, actually. It's a great addition if you're able to do it. It's pretty expensive, but if you're able to do it, it's nice. So it launched in, I believe it was the summer of 2020. And I do these applications for people too, and help them write their policies around this. And yeah, it's a lot. It does take a lot of work, a lot more policy writing. So the it certifies that a program is placing clients at the appropriate ASAM level of care, Addiction Society, American Society of Addiction Medicine, and the clinical standard for SUD level of care determination. So you can decide what level of care they're coming at 3.1, 3.5, 3.2. But if you have CARF, it would be 3.7 if they meet the criteria based off of the assessment. So, and, the intensity descends as it goes from 3.5 to 3.1. So the certification addresses one of the most significant gaps in the field, and that is inappropriate level of care placement. That's what we're trying to monitor here, trying to manage, make sure that really residents are in the appropriate level of care. And in the state of California, residential treatment programs are required to have a level of care designation. They are not required to have 3.7. That is voluntary. However, it could be pretty helpful. I hear that there are certain insurance companies that are requiring it in order to pay, even if California doesn't offer it. Some programs are getting it then, and then others are just saying, we're just not going to work with that payer. It's up to you what you think is best for you. Probably ask your biller. That's probably a good person to ask about this. So, yeah. So a program with LOC certification has been evaluated on whether the clients are actually placed where they clinically belong. It's meaningful and rare. Accreditation matters. I want to be clear about that. A program that has pursued and maintained accreditation has voluntarily submitted to independent evaluation against clinical quality standards, and that is not nothing, but is also everything. It is one data point, an important one, in a decision that deserves multiple data points. Ask whether a program is accredited. Ask when the last survey was. Ask what the findings were if you really want to take it that far. And then keep asking questions if this is something that is important to you. And it is important because accreditation is the beginning of the due diligence, not the end of it. Thank you so much for watching. And there's more on this because I am covering a compilation of articles that I have put together regarding the industry misconduct and fraud and addiction treatment, as well as compliance. That's my specialty. That's my job. That's what I love. So I'm hoping that this can be a place where people come and they get as much information about how to look for a high quality program versus a low quality program, because when you are calling the admissions team, they can sound the same. And you need to know the difference because we're talking about a serious condition that is stigmatized, and they need the help. They need all the help they can get, and they need to be able to trust the healthcare professionals. And that's what I'm aiming to do. So thank you so much.